In obstructive lung diseases like asthma, where individuals suffer from reversible narrowing of the airways, medications like bronchodilators are helpful in keeping the airways open. Now, based on their mechanism of action, bronchodilators can be broadly divided into four main groups: beta-2 agonists, muscarinic antagonists, leukotrienes antagonists, and methylxanthines. In this video, we'll focus on the bronchodilators like beta-2 agonists and muscarinic antagonists, which mimic or inhibit the regulatory effects of the autonomic nervous system on bronchial smooth muscle. Okay, so let's take a look at the lungs. You've got the trachea, which branches off into the right and left bronchi, and then continues to branch into thousands of bronchioles. In the bronchioles, you've got the lumen, the mucosa, which includes the inner lining of epithelial cells, as well as the lamina propria, which contains many cells like the type II helper cells, B cells, and mast cells. Surrounding the lamina propria, there's a layer of smooth muscles and submucosa. These muscles are innervated by the nerves of the autonomic nervous system, which means they can't be controlled consciously. The autonomic nervous system is made up of the sympathetic nervous system, which is involved in the flight or fight response, like running away from angry raccoons, and parasympathetic system, which is involved in the rest and digest response, like taking a nap after a big dinner. So let's say that raccoons are chasing you. The sympathetic nerves activate and release norepinephrine, which bind to beta-2 adrenergic receptors on the smooth muscles in the respiratory tract, causing them to relax. The diameter of the airways increases, and more oxygen gets to the lungs. When you're resting, there's less need for the extra oxygen, so the parasympathetic nerves release acetylcholine, which bind to muscarinic M3 receptors in the respiratory tract, causing smooth muscle contraction and narrowing the airways. Now, in conditions like asthma and chronic obstructive lung disease, such as emphysema and chronic bronchitis, the respiratory airways become narrower, which obstructs airflow, leading to wheezing, shortness of breath, and chest tightness. Now, the main difference between asthma and chronic obstructive pulmonary diseases, or COPD, is that in asthma, the airway narrowing is due to muscle spasms, which is reversible, while in COPD, it's due to chronic inflammatory damage to the airways, which is irreversible. Now, for asthma, we can use beta-2 agonists to relax the smooth muscles, or muscarinic antagonists to prevent muscle contraction. Now, although the airway obstruction in COPD is irreversible, bronchodilators can often present the complete closure of the airway during expiration, which provides mild symptomatic relief. Let's start with the beta-2 agonists first, which are also known as beta-2 receptor agonists. These medications come in an aerosolized form and are taken via inhalers. Once in the lungs, they bind to the beta-2 adrenergic receptors on bronchial smooth muscle cells. This activates the enzyme adenylyl cyclase, which leads to increased cyclic AMP production that ultimately cause relaxation of the smooth muscle. The effect is both fast and localized within the lungs, which makes these medications the treatment of choice for quick symptom relief with minimal side effects. Beta-2 agonists also stimulate the beta-2 receptors on immune cells like mast cells and decrease the release of inflammatory mediators like leukotrienes and prostaglandins. This in turn decreases the inflammation, swelling, and irritation in the respiratory tract. Ultimately, all these events help dilate the narrow airways and improve airflow. Now, based on the duration of action, inhaled beta-2 agonists can be divided into two broad groups: short-acting beta-2 agonists, or SABA, and long-acting beta-2 agonists, or LABA. SABAs include medication like albuterol, metoprolol, and terbutaline. Inhaled albuterol taken from a pressurized metered-dose inhaler, or PMDI, produces bronchodilation within 5 minutes, and lasts for a period of 2 to 4 hours. It's best used to terminate acute asthma attacks, but less useful for prophylaxis. They're also the medication of choice for exercise-induced bronchospasm, a condition where exercises can trigger asthma attacks. Side effects of SABAs are caused by increased sympathetic stimulation and include tachycardia, palpitation, muscle tremors, restlessness, and insomnia. Long-acting beta-2 agonists, or LABAs, include medications like salmeterol and formoterol. Compared to the SABAs, these beta-2 agonists have a slow onset of action, which is why they're not used for symptomatic relief during acute asthma attacks. But, because of their long duration of action, which lasts for over 12 hours, inhaled LABAs are used as a twice-a-day prophylactic or maintenance therapy for asthma and COPD. Side effects of LABAs are similar to the side effects of SABAs, but sometimes they can get exaggerated because of their longer duration of action. For example, LABAs can turn tachycardias into arrhythmias, which could result in heart failure and death. That's why LABAs are rarely used as monotherapy. Instead, in severe asthma, LABAs are added when the symptoms aren't well controlled by inhaled corticosteroid alone. This combination reduces the dosage needed for both medications, and subsequently their systemic side effects. Alright, now let's move on to the muscarinic antagonists, also known as muscarinic receptor antagonists. These medications are also given via inhalers, where they enter the lungs and bind to M3 muscarinic receptors on the tracheal and bronchial smooth muscles. This blocks acetylcholine from binding to the receptors, leading to less smooth muscle constriction. Now, ipratropium bromide and tiotropium bromide are the most commonly used muscarinic antagonists for asthma and COPD. Ipratropium bromide is short-acting, with a duration of 4 to 6 hours, while tiotropium bromide is long-acting, with a duration of 24 hours. In comparison to the beta-2 agonists, these medications are less effective for asthma, but more effective for COPD, where they are the bronchodilators of choice. However, for severe asthma and COPD, muscarinic antagonists are often given with LABAs, because this combination produces an additive effect, leading to stronger and longer-lasting bronchodilation. Side effects of muscarinic antagonists include tachycardia, dry mouth, restlessness, pupil dilation, and they're contraindicated in individuals suffering from narrow-angle glaucoma, since they relax the ciliary muscles, which worsens the obstruction of aqueous humor drainage. So now we want to make a simple and fun mnemonic that'll help you memorize and obtain all of these pharmacology facts. Let's have a 2-headed bee for the beta-2 agonists, and a 3-armed musketeer carrying a shield in each arm to represent the muscarinic antagonists that block the M3 receptors. The bee is relaxing with a tall friend and a short friend, which represents LABAs and SABAs. His short friend is Albert Einstein, which stands for albuterol. He's very self-conscious about his height, so he's wearing a turban on his head for terbutaline, and on top of that is a metal helmet for metaproterenol. Next to him is a wheezing jogger to help you remember that SABAs are used for symptomatic relief during acute asthma attacks and exercise-induced asthma. Next are the LABAs, and there's a very long salmon for salmeterol, wearing formal wear for formoterol. For indications, let's have a COP for COPD and a no smoking sign for asthma prophylaxis. For side effects of beta-2 agonists, there's the angry raccoon to represent sympathetic response. He's sitting up in bed because he's too angry to sleep, and his little heart is about to pop out of his chest. Next are the muscarinic antagonists, which will be represented by 2 tropical palm trees by the musketeer, since they have tropium in their name. The shorter tree has a rat in it for the shorter-acting ipratropium, while the longer tree has ties hanging off of it for the long-acting tiotropium. Since they're more effective for COPD and less effective for asthma, let's have a very buff cop holding a tiny no-smoking sign. For side effects, let's have a girl who's in love with the musketeer. Her heart's beating faster, she's got dry mouth, and her pupils are dilated. In fact, her eyes are almost popping out of her head, which represents the contraindication for people with glaucoma. Alright, as a quick recap. Treatment of obstructive lung diseases like asthma or COPD includes bronchodilators that cause smooth muscle relaxation and dilation of the bronchi. This can be done by stimulating the beta-2 receptors with beta-2 agonists, or it can be done by inhibiting the muscarinic M3 receptor with the muscarinic antagonists. Short-acting beta-2 agonists like albuterol are useful in treating acute asthma attacks and exercise-induced asthma, while long-acting beta-2 agonists and muscarinic antagonists are effective in prophylactic therapy for severe asthma and COPD. But wait, there's more! Here's a mind map with all of the mnemonics from the video. Go ahead and pause so you can test yourself to see what you remember. Stay tuned for the answers after the credits!